Clinical mastery of benign pancreatic disorders requires tracing a clear pipeline of failure, starting with the initial embryological missteps that create ductal choke points. We evaluate everything from the acute autodigestion of the gland to the chronic fibrotic destruction demanding complex surgical reconstruction. Normal function requires precise embryological fusion. The dorsal and ventral buds merge, routing the primary duct to the major papilla. If fusion fails, pancreas divisum occurs. These disconnected systems force the majority of exocrine secretions through the narrow minor papilla. This anatomical bottleneck causes inadequate drainage and increased ductal pressure, directly predisposing the patient to recurrent attacks of pancreatitis. Diagnosis requires MRCP as the investigation of choice. Treatment hinges on mechanical relief, specifically performing an ERCP with a minor papilla sphincterotomy to widen drainage. A different embryological error occurs when the ventral bud rotates. Instead of fusing laterally, the tissue forms a physical ring, encircling and constricting the second part of the duodenum to create an annular pancreas. Because this constriction occurs distal to the stomach but proximal to the ampulla, patients typically present with non-bilious vomiting. Contrast-enhanced CT will reveal a classic double bubble sign of duodenal obstruction. This anomaly is heavily associated with Down syndrome. Clinically, you differentiate it from duodenal atresia by the nature of the emesis. Atresia presents with bilious vomiting immediately from birth. These embryological missteps permanently alter the fluid dynamics of the exocrine system, establishing a lifetime vulnerability to obstructive disease. This happens before the patient has taken a single drink of alcohol or formed a single gallstone. Moving to the adult surgical exterior, the pancreas is defined by its deep retroperitoneal location and intimate wrapping around critical vascular structures. The most critical boundary for any resection is the plane between the pancreatic head and uncinate process and the superior mesenteric vessels. Surgeons call this the tunnel of love. Preserving this exact plane determines resectability during a Whipple procedure. Obliteration by severe inflammation compromises resection. At the distal end lies the sphincter of Oddi. This is a complex of 4 distinct sphincters: the choledochal sphincter, the superior and inferior ampullary sphincters, and the pancreatic sphincter. Sphincter of Oddi dysfunction causes biliary colic or recurrent pancreatitis. Diagnosis requires ERCP with manometry, demonstrating a sphincter pressure exceeding 40 millimeters of mercury. The Milwaukee classification stratifies severity. Type 1 requires pain, common bile duct dilation, and enzyme derangement. Type 2 involves pain plus 1 additional finding. Type 3 is characterized by pain alone. Together, macroscopic vascular boundaries and microscopic sphincter dynamics dictate the viability of surgical intervention and the ongoing risk for localized recurrent pancreatitis. Acute pancreatitis is a catastrophic chemical event. It is driven by the inappropriate activation of powerful digestive enzymes while still trapped inside the glandular parenchyma. This flowchart maps the co-localization theory, the primary model for how this cellular destruction begins. Pathological stimuli trigger a sustained elevation in intracellular calcium. This forces lysosomes and zymogen granules to merge. Trypsinogen activates prematurely inside the acinar cell, initiating violent autodigestion and releasing a massive wave of inflammatory mediators, specifically interleukin 1, 6, 10, and TNF-alpha. The stimuli that trigger this calcium influx are varied. Gallstones are the most common overall cause, driven by bile reflux into the pancreatic duct. Alcohol is second. In children, blunt trauma is the leading etiology. Iatrogenic injury also plays a role. Post-ERCP pancreatitis carries a 5% risk, especially in females or following difficult cannulations. Secondary triggers must also be ruled out. These include drug-induced causes from thiazides, antiretrovirals, or chemotherapy, metabolic spikes like hypercalcemia and hypertriglyceridemia, structural blocks like pancreas devisum, and specific geographical hazards like scorpion stings. Regardless of the trigger, the clinical presentation is uniform: severe epigastric pain radiating directly to the back, relieved only by leaning forward. Crucially, clinicians must recognize a specific pathognomonic discrepancy. The patient will report excruciating pain, yet their initial abdominal exam may yield surprisingly soft, benign physical findings. If the inflammation progresses to hemorrhagic pancreatitis, retroperitoneal bleeding manifests as bruising, Cullen's sign around the umbilicus, Gray-Turner sign on the flanks, or Fox sign in the inguinal region. Internally, the enzymes rip through the retroperitoneum, leaving chalky white fat saponification deposits visible upon exploration. Because the disease begins as localized cellular autodigestion and requires time to cascade into a systemic inflammatory response, early physical exams mask the internal destruction. Diagnosis does not rely on physical examination alone. Strict guidelines require patients to meet 2 out of 3 criteria: typical abdominal pain, characteristic imaging findings, and serum amylase or lipase elevated to at least 3 times the upper limit of normal. This line graph compares the kinetic profiles of the 2 primary diagnostic enzymes. Amylase rises early but drops rapidly due to a short half-life, and it can be falsely elevated by mesenteric ischemia, volvulus, or bowel perforation. Lipase, however, is highly specific to the pancreas. It rises later and sustains its elevation longer. It is critical to note that the absolute peak of these enzyme levels has 0 correlation with the actual severity of the attack. To gauge physical destruction, imaging is required. The protocol dictates a contrast-enhanced CT in the portal venous phase, timed for after 72 hours. Scanning earlier than 72 hours will artificially underestimate the extent of tissue necrosis. Once the diagnosis is confirmed, the patient must be risk stratified. The thresholds for severe disease are rigid: a Glasgow score of 3 or higher, Ranson's criteria of 3 or higher, an APACHE-2 score of 8 or higher, a modified Marshall score of 2 or higher, or a C-reactive protein level exceeding 150. This grid outlines Ranson's criteria, split across 2 critical timeframes. At admission, severity points are awarded for a white blood cell count over 16,000, age over 55, glucose over 200, AST over 250, and LDH over 350. Within 48 hours, the physiological toll is measured by a hematocrit fall over 10%, rising BUN, hypocalcemia, a PaO2 under 60, base deficit, and massive fluid sequestration exceeding 6 liters. A modern alternative is the BISAP score, measuring BUN elevation, impaired mental status, systemic inflammatory response syndrome, age over 60, and pleural effusion. This table breaks down the CT severity index, combining the Belfazar grade for peripancreatic inflammation, scored 0 to 4, with an anatomical necrosis score, graded 0, 2, 4, or 6, based on the percentage of dead tissue. A total score out of 10 is generated. A score of 6 or higher confirms severe pancreatitis. Clinical intuition alone cannot reliably predict which patients will develop lethal necrosis or organ failure. This exhaustive, multifactorial data collection is a mandatory survival protocol. Initial management prioritizes aggressive physiological support, strictly nil per oral, massive volume resuscitation with intravenous Ringer's lactate, and adequate analgesia. Modern protocols explicitly permit opioids. To maintain gut mucosa and prevent translocation, early enteral feeding via a nasal jejunal tube is preferred to bypass the duodenum entirely. Routine antibiotics are useless here. IV meropenem is reserved strictly for proven infected necrosis. Patient outcomes follow the Atlanta classification. Mild cases involve no complications. Moderate cases feature local complications without systemic failure. Severe cases display both. When mortality occurs, flowcharts show mechanisms are highly predictable. Multi-organ dysfunction syndrome drives early death, while overwhelming sepsis causes overall late-stage death. The intense retroperitoneal inflammation frequently damages adjacent vascular structures. Enzymatic erosion into the highly proximal splenic artery creates a pseudoaneurysm requiring embolization or surgical ligation. Concurrently, inflammation can induce splenic vein thrombosis. This creates left-sided or sinistral portal hypertension, often necessitating a splenectomy to resolve bleeding varices. The fluid dynamics of the damaged gland evolve predictably over time. Acute peripancreatic fluid collections lack a mature wall and exist before the 4-week mark. Beyond 4 weeks, these consolidate into mature, walled-off necrotic collections. The surgical approach to necrosis is strictly binary. Sterile necrosis is managed conservatively. Infected necrosis demands the step-up approach. Infection is signaled by fever, rising CRP, and distinct gas pockets on a CT scan. The approach begins with percutaneous pigtail catheter drainage and only advances to laparoscopic retroperitoneal debridement if the patient fails to improve. Modern acute pancreatitis management is an exercise in extreme restraint. The surgeon's primary job is to delay physical intervention until fluid collections definitively mature, obstruct vital anatomy, or become catastrophically infected. When pancreatic fluid leaks and triggers a localized inflammatory response, the body attempts to contain it. This creates a pancreatic pseudocyst, a localized collection of fluid completely enclosed by a wall of granulation tissue, distinctly lacking a true epithelial lining. It most commonly develops in the lesser sac, compressed precisely between the posterior wall of the stomach and the anterior face of the pancreas. These are categorized using the Digitio classification. Type 1 occurs after acute pancreatitis with normal duct anatomy. Type 2 represents an acute exacerbation of chronic pancreatitis. Type 3 is found in pure chronic pancreatitis and features a direct communication with an abnormal main pancreatic duct. Most pseudocysts resolve spontaneously. Surgical intervention is reserved for patients who meet the clinical 6-6-6 rule. The cyst must be greater than 6 centimeters in size, persist for longer than 6 weeks, and develop a granulation wall thicker than 6 millimeters. Once those thresholds are met, drainage pathways open. External pigtail drainage is possible, but surgeons must first verify there is no direct ductal communication to avoid creating a high-output pancreatic fistula. Internal drainage utilizes the mature cyst wall to create an anastomosis directly to the GI tract, most commonly a cystogastrostomy. Because food naturally tracks along the lesser curvature of the stomach, it bypasses the cystogastrostomy entirely, allowing the cavity to collapse and heal. Pseudocyst management demonstrates the necessity of time in benign pancreatic surgery. Attempting to suture a cyst before the 6-week mark, when the granulation tissue is soft and friable, guarantees structural failure. Waiting for the wall to mature is non-negotiable. When the gland fails to recover, acute attacks transition into chronic pancreatitis, a state of irreversible tissue destruction and fibrosis. Etiologies are categorized by the Tiger-O classification, encompassing toxic metabolic, idiopathic, genetic, autoimmune, recurrent, and obstructive causes. Alcohol abuse remains the dominant, most common etiology. Genetic markers also dictate disease progression. PRSS1 mutations drive hereditary pancreatitis and carry a massive risk of pancreatic cancer. SPINK1 mutations cause premature trypsinogen activation, often linked to tropical calcific pancreatitis. CFTR mutations connect chronic pancreatic destruction directly to cystic fibrosis. The clinical manifestations of chronic disease remain silent until 80 to 90% of the glandular parenchyma is destroyed. At that threshold, exocrine insufficiency triggers severe malabsorption and steatorrhea, diagnosed by measuring fecal elastase and treated with oral enzyme replacements like Creon. Simultaneously, the destruction of islet cells guarantees endocrine insufficiency, presenting as brittle diabetes mellitus. This side-by-side comparison shows the classic chain of lakes appearance visible on imaging. The investigation of choice is an MRCP with secretin stimulation. The secretin forces the pancreas to secrete fluid, rendering a ductal system heavily scarred by alternating strictures and massively dilated segments. Recurrent cycles of injury permanently replace functional enzyme-producing parenchyma with rigid, calcified scar tissue. The clinical battle shifts from surviving an acute localized attack to managing the lifelong consequences of exocrine and endocrine failure. Pain management in chronic pancreatitis always begins conservatively with analgesics. When the pain becomes entirely refractory, surgical intervention is dictated by a single metric, the diameter of the main pancreatic duct. A duct smaller than 5 to 6 millimeters is managed endoscopically via ERCP and sphincterotomy. A duct dilated beyond 6 millimeters requires open surgical drainage. The specific drainage procedure maps directly to the location of the disease. For a massively dilated duct choked with diffuse calcium carbonate stones, the Puesto procedure is used, creating a longitudinal side-to-side pancreaticojejunostomy. If the severe disease is strictly isolated to the distal tail, surgeons employ the Duval procedure, utilizing an end-to-end anastomosis. When the fibrotic mass is dominant in the head of the pancreas, The Baker procedure allows for a duodenum-preserving resection of the pancreatic head. If the patient suffers from both an inflammatory mass in the head and severe ductal dilation throughout the body, the Frey procedure combines Baker-style head coring with a Pusto-style longitudinal drainage channel. Surgical selection is dictated by the precise geometric destruction of the gland. Intractable pain with an enlarged pancreatic head demands a Baker. An alcoholic patient with a 10 mm duct packed with diffuse stones requires a Pusto. But no matter the surgical configuration, the clinician must remain vigilant for the ultimate complication. Long-standing chronic inflammation, especially in hereditary variants, significantly increases the risk of pancreatic carcinoma. The pipeline of benign pancreatic disease ends in the operating room. From congenital structural failures to the acute chaos of cellular autodigestion, surgical reconstruction offers the final mechanical salvage for an organ that has irreversibly destroyed itself.